Hello, gorgeous, and welcome to the Midlife Realignment. I'm your host, Esther Blum, and I'm here to disrupt the narrative on perimenopause and menopause with humor, nutrition, hormones, and fierce self-advocacy. Together, we'll rewrite your story and the rules because there's a light at the end of the vaginal tunnel. Let's go. Dr. Jolene Brighten is an internationally recognized hormone expert, nutrition scientist, and founder of Dr. Brighten Essentials, a supplement company creating science-backed solutions for women's health. Board certified in naturopathic endocrinology, a certified menopause specialist, and sex counselor. She's the best-selling author of Beyond the Pill, Is This Normal?, and the forthcoming ADHD and Women, empowering women to optimize their hormones and enhance sexual wellness. A passionate advocate for uncovering the root causes of hormonal imbalances, Dr. Brighten combines clinical expertise with evidence-based education to empower women to optimize their hormones, brain health, and sexual wellness. Through her writing, speaking engagements, and global educational platforms, she has inspired millions of women to understand their bodies and reclaim vitality. Grab a pen and paper, everybody, and share this with every neurodivergent woman that you know. This will be a game changer for you. Jolene, I'm so thrilled to have you on the show because Beyond the Pill has been on my bookshelf since it came out. I've given it to my clients, and now you have written this masterpiece, ADHD in Women. So thank you for coming on today.
Absolutely. I'm excited for this conversation.
Yes. Let's talk about why ADHD looks so different in women versus men, because you have taught me so much about this.
My children have taught me so much about this. So I have two sons, both ADHD. And, it wasn't until their diagnosis, my oldest diagnosis, that I was like, wait a minute, you're saying all this stuff is not normal? And the psychologist is like, no. In fact, we should talk because it's not normal. So, coming from that experience, I think I'm really in a unique position, like a lot of women who have ADHD and are parenting sons with ADHD. And we look so different. So there's really two big reasons why women with ADHD look different. Firstly, society punishes us when we don't act the way that we're expected. So from a very young age, ADHD women, they come to learn that mistakes are not just unacceptable. They're dangerous. You could lose community. You could lose opportunities. But in addition to that, you are always praised if you are people-pleasing, if you are smiling and putting your discomfort second to the pleasure of others. And so there's a lot of society influence, and we see this in the research. So for people who are like, is this just, a theory? It's not. What we see in the research is that as an adolescent is entering puberty, their ADHD experience becomes internalized. This is where they get diagnosed with anxiety, sleep disorders, literally anything but ADHD. And in reality, it's the society is influencing their behavior, and they're taught they have to take it all in. Now, the second thing that makes us express so differently with ADHD is hormones. And because of our hormonal experience, we are able to mask at a higher rate. So what does that mean? We're able to hide the struggle. We look put together on the outside. We are screaming, drowning, dying on the inside because it is so difficult. But because of the rise of estrogen, changes in progesterone, testosterone coming online, our brain is capable. It has the energetic capacity to actually mask the discomfort, mask the struggle, to put ourselves second, to show up for others, and to people please. And so this is why we see the ADHD experience. It's not just different for women, it's missed, it's misdiagnosed, it's attributed as anything else but ADHD. Now, the caveat here is if you look at the research, it will say PCOS women experience ADHD at higher rates. Now, we now call this PMOS, polyendocrine metabolic ovarian syndrome, but if you look at the research, it will still say PCOS because this is when the studies were done. Why is that? I don't think it's true that the PCOS, PMOS experience is actually higher rates of ADHD. I believe, and this is what I've seen clinically and what we see in the research, is higher androgens lead to more impulsivity, more hyperactivity, which is one of the classic archetypes, the expression of ADHD that we see in males. And so this has allowed researchers and doctors to say, this is how men present, and the PMOS experience looks the same. Therefore, ADHD for sure, and they have ADHD at a higher rate. Now, androgens do play a role in the symptom expression. They do play a role in the development of ADHD. A PMOS mom is 40% more likely to have a child with ADHD. In fact, just having hirsutism, a sign of hyperandrogenism, for everybody listening, that's high testosterone, high DHEA sulfate, high DHT, and many other androgens. When we see that, though, does that mean necessarily it's just the androgen experience, or is it that we're so much better at catching the male form of ADHD?
Even though if you go to get tested for ADHD, the testing is the same for men and women, or girls and boys, right? So is the testing picking up ADHD in women or girls the same as it is in boys?
This is such an excellent question. Now, what we understand is that the majority of women being diagnosed with ADHD are being diagnosed in adulthood. The majority, more than half, are entering adulthood before anybody discovers ADHD, with the highest cohort being perimenopausal women. So when you look at the screening exam, yes, the questions are the same, but it's also subjective to the person's experience. And because women have been taught, we've been gaslit, right? We've been taught not to believe ourselves. Medicine has ingrained in us that we can't be trusted to know our own experience. Only those outside of us who have a white coat, they're the only ones who could possibly know what's actually happening to our body. So there's part of that, right? There's part of do you truly know yourself? Can you be honest about the experience, or do you maybe mask and hide things because it's shameful? It hurts. Some people have rejection sensitive disorder. So RSD, they feel physical pain when there is emotional shame or criticism. So that can make it difficult for somebody to, be honest. It's often what we see is when someone else in their life gets the diagnosis, and that diagnosis holds a mirror up to themselves. And then they're like, oh, wait a minute, there's something more here. There's something else going on. So I think this is important to understand that, and I'm not blaming women for this. So firstly, that, maybe we're not as honest in the intakes. We think we are being, but, not quite. The other aspect of this is that when they survey clinicians, the majority of clinicians say, I don't know how to diagnose or treat adult ADHD, because our focus has been entirely on making children sit still in a classroom, children behave in a classroom, right? As we expanded a classroom from 20 students to 36 students, and then instead of saying maybe this teacher needs some help, we had to say these students must be dysfunctional. We have to focus there. So I think that's just important for everyone to understand. Screening exams are the same, but the way we show up, the way we behave, and then the way we are perceived. So let's just take hyperactivity as an example. So hyperactivity, people think someone who can't sit still. They're jiggling their legs all the time, right? They're fidgeting in some way. They're getting up constantly. This is the coworker that's constantly going to the water fountain, right? Except that hyperactivity for a woman may look like hyperactivity in the mind. So her thoughts are racing. She's, listening to a conversation while she's also writing a speech and getting ready for a PowerPoint presentation and thinking about her grocery list. It is all this hyperactivity. She tries to go to bed at night, and instead of falling asleep, she replays every event of her life, ruminates on it, right? And that's what it gets called, rumination. But it may actually be a symptom of ADHD, in which the mind chatter won't stop. Her brain will not shut up.
Does every woman then in perimenopause have ADHD, or does perimenopause just make existing ADHD harder to ignore? How do you know if you have, which is the chicken and which is the egg?
This is such a great question. And in ADHD in women, I go through this and I explain to women that even if you don't truly have ADHD, but you have ADHD-like symptoms in perimenopause, everything in the book can help you. So here is something that I want women to understand. Perimenopause does not cause ADHD. It can unmask ADHD and make it more apparent. We can talk about the hormonal influences there that make that happen. But women can also experience ADHD-like symptoms in perimenopause. Now, here's the good news. If you do not truly have ADHD, this like brain fog, dropping words mid-sentence, feeling like your executive function has fallen apart. So that's the, operations that we run through the prefrontal cortex, like planning, organization, time management. So if that's, if you're someone who's like, okay, I never had this problem my entire life, except in perimenopause, good news. That should go away about 2 years after your last menstrual period. Your brain should recover. However, what we understand is if it's truly ADHD, 25% will go on to have severe ADHD symptoms for the rest of their life. Now, I'm going to tell you how we differentiate these things, but here's another clue. If your perimenopause came sooner, if your mom's perimenopause came sooner, so ADHDers tend to hit perimenopause about a decade sooner with twice the symptom severity. So when anybody's like, why is it so hard for you? Why do you think you need hormones? Like, I went through it and it was totally fine. Congratulations, you can get a blue ribbon. Like, fantastic. But I need you to understand that the ADHD experience is not just worsening ADHD, it's that plus twice the symptom severity of perimenopausal symptoms. So we're talking about far worse hot flashes, night sweats, but don't forget that we have brain fog, itching ears, ringing ears, like dry vagina, itching skin. There's so many symptoms of perimenopause. Now, how do we know? Is this new onset ADHD? Well, JAMA says there's no such thing. There is no such thing as new onset ADHD. There can be acquired. If you had some kind of brain injury, you can acquire ADHD. But what it actually is that ADHD is apparent since childhood. So when you dig into someone's history, this is how we differentiate what's going on. And it matters because, like I said, if it's truly ADHD, we have about a quarter of those women who are going to struggle. And if you might think, sometimes ADHD on the internet is like, oh, I mismatched my socks. I'm gonna disclose something about myself right now that I've been struggling with, like as I enter 45 and a half. I forgot to put mascara on today. I don't know why every luteal phase. I cannot remember the last step, which is mascara, right? Okay, so that's just like quirky things of ADHD. We're talking about people who miss screening exams, who need medical treatment, who don't follow through on it, who miss mortgage payments, who are more prone to getting into car accidents. And if they're not getting adequate treatment, they're more prone to substance use. Why is that? I mean, if we look at alcohol, nothing's going to raise GABA faster than alcohol. Fantastic, maybe oral progesterone, but it's going to be to your detriment, right? There's too many side effects with using that. So we want to go back and we want to ask, what was it like in your childhood? Now, this is usually when women will say, no, I could sit still in class. I wasn't somebody who, was always fidgeting. They start, making a case for themselves. And I ask things like, did you get on your report card, she's smart, but she talks too much? Gasp. Okay, hang on. What? Yeah. Did you talk? You just like talk all the time? Like, did you have difficulty with your relationships because you interrupted people like mid-sentence? Or are you one of those people that like when someone talks about them, so their struggles, you start talking about yourself because that's how you relate, right? Oh, except they're mad because now they're like you're self-centered. But no, that's how you understand how to relate. Are you the person who, you can make appointments for your kids, your husband, like you have everything put together for them, but for yourself, you don't remember your last pap smear or breast exam. Like you have no idea. Oh my gosh. Yes. Are you the kind of person who watches the TikTok and you're like, oh yeah, I'm going to meal prep. I'm going to plan. I'm going to do all of that. You buy all the things and then you can't you just don't have the steam, the energy to like follow through on that. Has this been your story your whole life? Like, were you the gifted child? Were you the straight A child because you had to excel at something? Because if you didn't, you had no value and everybody was criticizing you nonstop about your life. We start to look at the ways that female ADHD shows up. Were you ever diagnosed with anxiety. Did you find that like before your luteal phase, so for everybody listening, we pass ovulation, we go into a progesterone dominant phase, and then right before our period, that's going to be the end of the luteal phase. Did you find that that's like the worst 7 to 10, maybe 14 days of your life, like month after month, like nonstop? Like we start looking at all of these patterns from childhood into your 20s, into your 30s, maybe you're in your 40s now, and it starts to put together a pattern and the puzzle pieces. And what we find is you pass 35, or maybe you're someone who, you don't start to struggle until 45. And then what we find is that, yeah, I used to be able to hold it all together. I used to be able to do all of these things. Now I can't do it. All the tools, all the scaffolding, every thing I had in place, it doesn't work anymore. Welcome to hormone changes. Welcome to like the second puberty. And then we go back. Let's talk about what puberty was like for you. And it's usually a lot more extreme for ADHD women, which we don't have research saying, hey, perimenopause, that's hell. We have that for ADHDers. We don't have it for puberty. But I've seen this clinically time and again where it's like, everybody talks about how hard puberty is, right? And it is hard. For the ADHDer, it's so much more amplified.
Mm-hmm. Huge. And then women in perimenopause have the added complication with ADHD when they try to add in progesterone. What percentage? Now, this is really why I wanted to get you on the show, because I was fascinated watching you talk about how often women with ADHD have adverse effects with progesterone. So what percentage of women have you seen come across this issue, and what does it look like? What do the adverse reactions look like, and what are the workarounds for women?
Right. So what you're talking about here is progesterone sensitivity, which is a new phenomenon only in like the last handful of years that's coming out in the research. There are still, true to how clinicians do, denying it. And I think it's really problematic that perimenopause, menopause is like having its day. But so many of these clinicians, they're really at the forefront, that have like the biggest followings. They've only been prescribing hormones for a handful of years. And why I think, so firstly, everyone's got to start somewhere. But what I think is problematic is that there's this cookie cutter approach of everybody gets the estradiol patch, everybody gets 200 milligrams of oral micronized progesterone, and everybody gets 5 milligrams of testosterone. And I'm like, this is just not, like, as someone who's been doing this for 15 years, this is not how this works. So progesterone sensitivity, people are like, what is this? Okay, so we see women who have a paradoxical effect. I remember the first patient, this was probably 13 years ago, that I put her on progesterone, and she was like, I feel so depressed. I'm crying all the time. I'm like, okay, we got to lower the dose. It wasn't working. And then it was like within 2 weeks, I had another patient who we're like starting estrogen therapy. Therefore, she has a uterus. We have to start progesterone therapy. And she calls me. She's like, I got in with my psychiatrist. I feel suicidal. Like, I don't know what's going on. And I'm like, stop the progesterone. Stop the progesterone right now. So what we've come to understand now in the research, and I'm really grateful for this, because all of this time I've just been like, okay, some women are very sensitive. I do see an inflammatory component, and if we can modulate inflammation, we can sometimes get progesterone response to be better. However, now the research shows us some women are rapidly metabolizing progesterone to its neurosteroid metabolite, which is allopregnanolone. And that docks on the GABA receptor and says, hey, let's work with GABA really well in the brain. Let's feel chill. Let's feel calm. Let's get some good sleep. And then women who it works for they're like, I never felt so in love with my life. Like, this is amazing. Women who it doesn't work for, they have this paradoxical effect. They can feel rage, anxiety, they can feel suicidal, they can feel incredibly depressed, they can have insomnia. So it may be that they rapidly metabolize, they get way too much allopregnanolone. But we also understand by looking at the PMDD research, which is premenstrual dysphoric disorder, that there is dysfunction in the GABA receptor. And there may be a lack of GABA neuroplasticity to adjust with the menstrual cycle. So if you're someone who experiences this cyclically, that may be the issue. Neuroplasticity is struggling But the other thing is that we may just see this dysfunction. Now, I've observed for a very long time that it is my ADHD, my autistic, my OCD, my bipolar. Like, you put them in the umbrella of neurodivergence, and they're going to be more likely to have this progesterone sensitivity or intolerance. Well, we just got research a few years ago, and actually there was even a more recent study that showed that ADHDers, they're like at a 36 to like 43% increased risk of PMDD. They're 3 times more likely to have PMDD. With autism, there was one survey where over 95% of autistic women expressed having symptoms of PMDD. So what is PMDD? Neuroinflammation. There is dysfunction at the GABA receptor. There is an intolerance to the allopregnanolone. There are histamine components. All of these things we also see with the neurodivergent women. So it is complex. We need far more research to understand how can we screen for this? How can we treat this? But, some of the workarounds that I talk about, I did a whole episode of the Dr. Brighten show on this. So sometimes we go slow release. So, and here's something for everybody listening. If you're going to work with somebody for hormone replacement therapy and you're like, ooh, I feel like maybe I might be the progesterone person. Maybe pregnancy is really hard for you. Maybe you have a history of PMDD. Ask the provider, have you ever worked with a compounding pharmacy? If they say to you, no, there's no reason, that's not FDA approved, this is like, that is seriously disinformation. They'll say all of these things. They don't know how to work with neurodivergent women. I will tell you that, because neurodivergent women, they can have sensitivities to that estradiol patch. So they might have a reaction to the adhesions in there. When it comes to progesterone, we might need a slow release capsule if we're doing it orally. That allows more of a slow, sustained release and conversion to allopregnanolone instead of this bolus. You can only do that via compounding. The 100 to 200 milligrams prometrium might not work for you. We might have to go a vaginal route. Some people go a rectal route. I never like to start there. No one wants to put anything up their butt, all right? So there's so many women out there that are like, why do doctors not start there? And I'm like, because if I can get you on maybe 25 milligrams oral of progesterone, and then we can do like a suppository if we need to protect the endometrial lining, which for everybody listening, the Menopause Society of the US, their guidelines say oral progesterone only for protecting the endometrium. The British Menopause Society is like, hold up, not everybody tolerates this, and women need estrogen. So let's use vaginal as an alternative. And you need to use the same dose, if not higher. So sometimes you need like 300 milligrams of progesterone. So we can look at going different routes. But because I'm not just looking at like giving you hormones and calling it a day, I also want to look at, do we have maybe an inflammatory condition like PMOS, endometriosis, adenomyosis? Is there gut dysbiosis? Because, we all talk about the estrobolome with estrogen, but we also, the gut microbiome is involved in processing our androgens, our progesterone, like every single hormone. And so we don't have research in that arena because estrogen's the it girl and she's all anyone wants to talk about. But that I also see playing a role, as if there's gut dysfunction, we have to be addressing that as well.
Yes. And with neurodivergent populations, the gut should, well, with anybody, but especially with neurodivergent populations, you always want to optimize the gut to make sure there's no candida or dysbiosis or bacterial overgrowth, and that you're not only absorbing your nutrients, but that you are detoxifying your hormones in that place, because that makes a huge difference. But I love that you talked about there's a real paradoxical effect with dosing with progesterone. And it's awesome to get a compounding pharmacy to prescribe 25 milligrams at a time so you can titrate up slowly. Or some women do well with 300 to 400. And it's just that 100 to 200 milligram range for progesterone that really does them dirty. So that's the most research I've seen, is like the paradoxical effect on dosing. But what effect does vaginal or rectally inserted progesterone have on the allopregnanolone and GABA receptors? How does it affect that? Like, is that as problematic?
Well, what women report, we don't have great studies. So the majority of research we have is on progestin. And I need everybody to
Yeah.
understand progestin is patented, and you can make a lot of money on progestin when you compare it to progesterone. So that's why so much research is on progestin. We see the same in the endometriosis community, where providers won't use progesterone because they're like, oh, the research is on progestin. I'm like, well, some women feel like they're losing their mind on progestin. So like, maybe we got to get creative here sometimes. So what's important to understand is that we have to listen to women and all of this, and this is what guides where the research goes next. So what women say is that I can tolerate vaginal or I can tolerate rectal. Well, when we swallow anything orally, it's going to go through the liver first. The liver is going to take a crack at detoxifying it, and we're going to see this conversion into allopregnanolone. We will still see conversion to allopregnanolone, but it may be slower and more steady when we use vaginal or we use rectal. This is like a TBD in research, but it does make sense because we know that, if we're using topical or vaginal estrogen, for example, that's not going to affect the liver in the same way. We're not going to get the clotting factors. Like, it's not going to have that first pass. And we understand this pharmacokinetics from like taking oral contraceptive pills or taking oral estradiol. And so that's the thought right now, is that because you're using vaginal or you're using rectal, that we're going to have a slower increase in allopregnanolone. Still, some women cannot tolerate it. And there's some women who are like, I will only be able to do 10 to 12 days on, and then I have to take it off. And they're not cycling, right? This is like a 60-year-old woman who's like, this is all I can tolerate. Sometimes women are better if they just stay on it consistently. And still, there are other women that they have to go through transvaginal ultrasound monitoring because they're using estrogen, and they have to have induced withdrawal bleeds sometimes, that we're doing that in perimenopause as the periods are becoming more erratic, and we're monitoring that. That's not preferred. We don't want to be risking endometrial cancer. So I want people to understand that's why progesterone is so important. And that's why I always advocate, get it figured out before you need estrogen. Because you're going to need progesterone in perimenopause before you need estrogen. Figure it out. Spend sometimes the year it takes figuring it out so that you can be a candidate for estrogen, and that things are pretty smooth after that. Now, there will be people who argue, we can't be using the vaginal estrogen to protect the endometrium because there's no research on that for menopause. We use that all the time in fertility care. So in fertility cases, to build the endometrial lining and to make it so it's perfect for the implantation of the embryo, vaginal progesterone is used.
Okay,
and
so you meant vaginal progesterone to protect the endometrial lining. Okay.
Did I say something else?
Well, you said estrogen, so I just wanted to make sure.
Thank you.
Okay, no problem. I knew what you were thinking.
I was like, did I say
yes?
estrogen?
So vaginal progesterone, yes, to protect the endometrial lining.
Progesterone. To protect the endometrial lining.
Okay.
It's and we don't worry about vaginal estrogen for endometrial hyperplasia.
Correct.
We do for topical, just to clarify that. And sorry that I misspoke there. But yes, the other thing that is interesting is that, so in fertility care, they do intramuscular injections of progesterone in the United States. I am not a fan of that. It's very painful. But in other countries, we are seeing subcutaneous progesterone is now available. That tends to be well tolerated. It's only used, it's used every single day. So you have to inject yourself every single day. Nobody really loves that. But I think this is an interesting avenue that we might need to start exploring in the research as an alternative, because I have had patients who are going through IVF and they're like, oh my God, oral progesterone, I'm a monster. Injected subcutaneous, and I have never been happier in my life. And I'm like, I need to understand this. And I think it's because you inject every 24 hours because it's sustained over a 24-hour period that this little bolus of progesterone is entering your system. And so does that protect the endometrial lining? That's the big question here. And I want everyone to understand, well, you may have mood symptoms. We have to be so careful that we're not inducing endometrial cancer. And if you have a history of endometriomas or endometriosis whatsoever, even if you've had your uterus removed, if you still retain your ovaries, we also need to use progesterone so we don't increase your risk of ovarian cancer.
Amen. Yes. 1,000%. You know your body. When you think your hormones are off, you're right. When you think your gut function is off, you're right. In 30 years of practice, every woman who came to me knowing something was wrong was always right. My Make Menopause Your Bitch Elite program is where we do targeted testing that makes it impossible for you to fail. I look at your blood work, Dutch, and GI map tests and build a targeted protocol based on what's happening in your body. You come in exhausted and dismissed, and you leave knowing exactly what to do. Apply at estherblum.com/MMYB. You don't have to suffer, and you don't have to do this alone. Apply at estherblum.com/MMYB. Let's talk about really optimizing the brain, cognition, and mood. What are your favorite levers to pull when it comes to diet, when it comes to supplements and nutrients? And where does testosterone fit in the picture with this?
Okay, if I forget any part of this
I will,
multiple part
yes.
question, you prompt me.
Yes,
Okay,
I will
so
prompt you.
firstly, I want to come back to the diet because you mentioned how neurodivergent individuals need to work on their gut health. And this is absolutely true. So in my book, ADHD in Women, there's actually 2 chapters on gut health because I'm like, I need you to understand your microbial diversity is likely garbage. I'm so sorry. I hate to break it to you. We know this from the research. There's poor microbial diversity. And when you enter into menopause, when that estrogen is finally gone, your microbial diversity tanks even more. So this is not to shame and blame anybody. It's to say, okay, let's recognize the operating system we're working with and let's optimize for it. So yes, we want diversity of fiber. I talk about in the book, microdose your microbiome. Don't worry about did you get 2 tablespoons of chia seeds? If you hate the texture of chia seeds, can you just give me 1/4 teaspoon? Can you just do a tiny bit? Because even if you do a little tiny bit, that's going to help shape and change your microbiome. We often think we have to overhaul our entire diet. With neurodivergent people, we have to recognize there are food aversions, there are sensory sensitivities, there's executive dysfunction that leads to inability to eat food, there's emotional dysregulation. So when I say neurodivergence, just for everybody listening, that's not just ADHD, it's not just autism, it's a huge branch of a lot of conditions. And neurodivergence is not a medical condition, just so we're clear. That's not a medical diagnosis. It's just a way to speak about it's not exclusively ADHD. It is across all of these different conditions. So one of the most powerful things I'll say that you can do though is polyphenols and focusing on getting more polyphenols. So yes, vibrant fruits and vegetables, like all the rainbow, right? All the colors. But a lot of people still struggle with that. Can we do herbs? Can we do dried herbs? Can we do teas? Starting to look at different ways that we can bring in variety that isn't make you gag on a vegetable. I do have to share, I out myself in the book as somebody who absolutely hates eggplant and will gag at the thought of it. I was just at a speaker dinner for a conference and they served eggplant as the main dish. And I was like, girl, you are so grateful you're around ovulation because man, can you suck it up right now? But if I was about to get my period, my sensory aversion, I'm white knuckling just talking about it.
Oh gosh.
But
oh my
my sensory aversions are so bad. So polyphenols, variety of diet, and then we want to look at how we fuel the start of our day. Breakfast is about probably all you can guarantee that you can control. And this is where I talk about get adequate protein, get adequate fiber, check the boxes early in the day so you have better blood sugar regulation throughout the day. The phenomenon of ADHD, what I need people to understand is that it's a full body experience. It's not just what's happening in the brain, but what is happening in the brain is poor glucose utilization and a lack of energy production. There's dysfunction of the mitochondria. And I talk about in the book the hormone, immune, brain triad with the mitochondria as the collateral. So we have to look at how can we get sustainable energy starting in the day, because your operating system, it's not so great. It's not so great with producing its own energy, which leads me into the other thing I recommend. So if we think about the mitochondria is the main power supply to the entire house, then exercise is your hand crank generator. You literally got to move to crank that energy. So while the ADHD brain can struggle with glucose utilization, and this is part of why insulin is one of my ADHD hormone profiles in the quizzes that you take in the book. You don't need insulin to actually pull glucose into the brain cells. But we know when there's insulin dysregulation due to the full body experience of ADHD, the behavior, the way that we eat, that we can see more dysregulation in dopamine and other necessary neurotransmitters. So exercise is going to help with blood sugar utilization, right? We're going to actually move that glucose out of our bloodstream into our cells. It's going to help with insulin sensitization throughout the body. But exercise is going to build up something called lactic acid. When your muscles burn, when you feel sore the next day, you're like, I hate lactic acid. But my friend, lactic acid goes to the brain, converted into lactate, becomes an energy supply for your brain cells. And this is why ADHDers need to fidget. This is why they need to move. This is also, I will say, I was on a podcast and I was talking about how my husband drives me nuts because he also has ADHD and he's constantly fidgeting. And then I realized, well, I'm a Latina and it's socially acceptable for me to talk with my hands. So I'm actually always fidgeting, that it's natural. It's like I talk with my hands. That's how I talk. But that movement is keeping my brain fueled. And so this is why if you have an inclination where you're like, I need to stand up, I need to move. If a child needs to shake their leg, yes, they do. Because it's the only way to keep their brain going and to keep their brain awake. Now, here is where it gets really messy for the operating system and why, you know, the approaches out there that just say like, oh, wow, you're in your 40s, just exercise, like just lift weights. Okay, yes, that's important. However, we have to understand the unique operating system of ADHD, and that 70% or more struggle with sleep and they have delayed sleep phase syndrome. Their melatonin doesn't rise until like midnight instead of 9 or 10 a.m. Well, here's the thing. If you don't get adequate sleep, you don't clear the lactate from your brain, now it works against you the next day. Now your brain can't actually work. It's not going to use the energy that you thought you had there. And so it's why we have to look at these unique aspects and fine tune some of these things.
Mm-hmm. And so what are your favorite AM and PM nutrients that really help regulate everything from insulin to sleep production to mitochondrial support? What are your, let's say, top 3 to 5 go-tos that you keep?
Right. So we talked about the macros. We talked about like getting adequate protein and all of that. If you are iron deficient, so if you have heavy periods or, you struggle to absorb iron, we have to replace iron because iron is a necessary cofactor in producing dopamine. And ADHD is far more than just a dopamine story, but dopamine is definitely involved. But I want to say, if you are not iron deficient, that will work against you. You will have more oxidative stress. So don't just go and supplement with iron. Now, the other thing, if we're talking about like ways to start your day, I think saffron, citicoline, bacopa, B vitamins, those are all really great things to consider. B vitamins are needed. They're cofactors for making our neurotransmitters, for making our hormones. They're needed for like literally everything. They'll also help with sustained energy, mitochondrial energy production as well. When we talk about, saffron is a really interesting one, and not just any saffron, and not drinking it as a tea or a spice. I wish it was that easy. The very specifically clinically trialed forms of saffron have been shown to help with improved mood, and they've done studies in children alongside Ritalin or methylphenidate. And what they have found is that it makes the ADHD meds work better. The saffron can actually help. We've also have studies on saffron and ADHD, it being really having a positive effect. Same with bacopa, which acts as an antioxidant in the brain. And then there's citicoline, which is more studied for memory and for neurodegenerative diseases, but it really helps with memory. And so these are three I absolutely love. I have a supplement called Radiant Mind, and I put them all in there for this very reason, all of the research on it. And because I was like, I'm not about to be a 45-year-old perimenopausal woman that's like struggling with her brain. Like, I can't do that. I have a 5-year-old, you guys. I can't do that. Now, in the evening, I would look at things like L-theanine. There's great research for L-theanine and ADHD, and it can help with getting into deep restorative sleep. Magnesium is another cofactor that you're going to need in order to make very specific neurotransmitters to detoxify your system. And so I would take magnesium glycinate is what I usually recommend. It's cheaper than threonate, which, I think some people do well with threonate. That's just really expensive, and it can become very cost prohibitive, and it's less bang for your buck when you're a woman with a uterus that's still menstruating, because the magnesium glycinate, that can help with your sleep, but it also can help with menstrual cramps. It can help with prostaglandins so that you're not getting period poop. So a lot of benefits to that.
Anxiety,
and then the other thing
too.
I would say, yeah, I mean, what does like magnesium not do? I really love it.
I know.
So
Blood sugar. Yeah.
yeah. And then, looking at the evening, and just so everybody knows, I have supplement tables. I have a whole chapter on supplements and the science for ADHD. And then I go into here's for each hormone profile that you have, supplements to consider. And so that's the other thing we want to look at is like, if we have a PMOS picture, maybe we're using myo-inositol at night to help us get some sleep and to help with blood sugar regulation, maybe with some chromium as well. Maybe somebody has a need for zinc. I always like to get that from food if we can, but maybe they're a vegetarian, and zinc is necessary for making your neurotransmitters and the actual the receptors work correctly. The other thing is like maybe someone has the cortisol profile. Their cortisol's high at night. Maybe I'm going to use phosphatidylserine at night so we can gently bring down that cortisol and coax them into being able to get some sleep, because so often people reach to melatonin for sleep. In ADHDers, there has been some research showing that melatonin actually backfires on some of them. So giving them melatonin, and especially higher, when you pass 3 milligrams of melatonin, they're more likely to stay up. Like, why? Like, why can't anything just be simple for us? But instead, I'm like, why don't we look at lowering neuroinflammation, which, the saffron, the bacopa, those things can be really great. Omega-3 fatty acids, which everybody always wants to reach for DHA. It's actually EPA we want. So why don't we look at lowering neuroinflammation and then supporting so that serotonin goes into the melatonin pathway, and then doing the sleep hygiene, and then maybe bringing on things like L-theanine, passion flower, like things that are going to help your nervous system calm and regulate itself at night so that we can get you into that deep restorative sleep that you need. So, I would love to be like, here's everything for everyone. There are key ones, the key supplements that I'm like, yes, these work so well for ADHDers, but then it starts to get a little more fine-tuned, which is why you'll find in chapter 2 of my book this whole quiz that helps you understand your ADHD hormone profile and then how you really want to dial in the protocol to be able to support yourself. Now, the last one I do want to add is creatine. I think creatine is phenomenal. Someone needs to drink her creatine for helping with brain energy production. So we know it helps with generating ATP. And so with that, though, I do want to say, so there's been big concern about what about endometriosis? I actually had someone yesterday comment to me and say, it's been proven that creatine worsens endometriosis. No, it has not. So let me explain this. And let me also say, let's be cautious because placebo is real. And that is not to say you make stuff up and it's in your head. It's to say you are that powerful. That we know
Yeah.
that I could give you something. I could give you a sugar pill, but I tell you it's going to work. And if you trust me and you believe in yourself, like you're going to be like, yes, this works. And I think that's a bit of the phenomenon we're starting to see with creatine because of the sensation. Like people have taken the research and they've really bastardized it for the pursuit of popularity on social media and going viral. So people will say supplementing with creatine has been proven to show that it makes endometriosis worse. No, it has not. They have never done a trial. They've never done a human clinical trial and shown this. They also have never done a trial where they actually supplement orally with creatine. In rodents, they injected their peritoneum
Ouch.
with creatine.
Ow.
It did not pass through the intestines. It didn't interact with anything microbiome-wise, right? Like it just went right into their peritoneum and they flared. Okay, well, yeah, because if you inject stuff into my abdomen, like my immune system doesn't like that. So that's where I'm like, you can't say it's the same. Now, they have found a correlation between people with endometriosis possibly having higher levels of creatine. And so that's like, okay, well, maybe there's a correlation and a proposed mechanism that it's actually affecting the immune system. So the immune system doesn't clean up the endometriosis lesions. But it's like also the immune system doesn't really clean up endometriosis lesions so well. It's actually better at just making scars. So at this point, we don't have any data on that. As someone who has endometriosis, adenomyosis, I do take creatine every day. I've never experienced a flare. That's my personal experience. There are women saying, I have experienced a flare, and that's when I'm like, then let's pause, and I want to ask questions. I want to listen to these women. I want to understand why. Something that I'm coming to discover in the women who say I have flares, they're rapidly increasing their creatine. So some gym bro on the internet says that like the ideal is to get to 10 grams a day, and I'm like, bro, what? Like, is it endometriosis or is it gastrointestinal distress? Because endometriosis leads to gastrointestinal distress. So it's that like, okay, what is actually going on here? And so typically I'm recommending people stay at 3 to 5 grams. You don't need more than that. The other thing is that women have said, you know, I heard Rhonda Patrick talking about the study, and so I went and took 20 grams of creatine because I didn't have good sleep. And I'm just like,
duh.
You're not in a clinical trial. Please don't do that. I laugh because I'm like, I get the temptation to do that. But yes, creatine can cause gastrointestinal distress. If your tum-tum gets upset as a woman with endometriosis, your endometriosis usually gets upset as well. And so more is not better, but it can be beneficial. But listen to your body. If you're like, I started 3 grams and I felt horrible, maybe that wasn't for you. Also, quality matters. If you're out there at a big box store and you're purchasing creatine, I'm always like, was it creatine? Like, was it the creatine that flared you, or was it all the junk they put in there so that they could pretend that you were actually getting what you were paying for? Because you were not.
Yes. Agree with you on all those points. Yes. Okay. The final part of that 3-part question is, where do you see testosterone in what role does that play in women with ADHD? Have you seen benefits? Have you seen downsides? Is there a paradoxical effect? Because we know in women who do not have ADHD, certainly it plays a role, a huge role in cognition, memory, and mood. But in someone who is neurodivergent, have you seen a different experience?
What I will say is that if you are a woman who's a candidate for testosterone, I tell my patients to hide their credit cards for the first 2 weeks that we start testosterone. And the reason is because even if we have the dose right, when that testosterone hits the brain, you can become far more impulsive. And it's usually temporary, but it's just more of the brain being like, woohoo, testosterone. And then you find you're more impulsive. I actually, I shared my story online that I had knee surgery. That's a significant stressor. I couldn't gain muscle back. My orthopedic surgeon would not discharge me from surgery because he's like, you are losing too much muscle. Your strength is gone. And I'm like, I'm working out 3 times a week. I'm lifting weights. I'm training my legs. He's like, maybe do less. I'm like, I don't think so. We're like restricting blood flow. I'm doing like, stim, like electrical stim units. I'm doing all this stuff. And then I'm like, wait a minute, let me test my hormones. I had such low testosterone. I'm like, oh my God, this is like one of the worst cases of low testosterone I've seen. Yes, because I went through a major stressor, which is a surgery. I also had a second trimester pregnancy loss like several months before that. Like that is just too much for the body. And so I was faced at 45. Do you try to get your testosterone back naturally? No, you don't, because you do not have time to lose this muscle mass. You have to put this back on. I go in testosterone. Within 3 months, I'm gaining muscle, doing everything the same amount of protein intake, same workout, gain a centimeter circumference in my thigh muscle, which my oldest son's like, how do you know that wasn't fat? I was like, because I didn't, it's not fat. Trust me, child. Like I didn't gain weight. Pants fit just fine. So, I share this because what happened to me is I started testosterone. This is like around Christmas. I'm in the mall doing some Christmas shopping and I'm like, we should get a puppy. My husband's like, what? I'm like, we should just get a puppy. Let's just do it. It'll be so fun. And all this stuff. And he's like, He's like, let's go to another store and like, let's just walk around and let's just think about it. We're not even going in the pet store. And I go in the other store and I end up buying 2 pairs of sequence pants instead. And he like reminds me that like you started testosterone and you always talk to your patients. He's like, you tell them, hide your credit card, be ready. And he's like, and here you are wanting to get a puppy. I got 2 pairs of sequence pants. I don't wear them, but oh gosh, it wasn't a puppy. So just be prepared for that. Testosterone though is absolutely so necessary for the female brain and the female body, but especially for ADHDers. So every woman will struggle with lack of motivation, low mood, but for the ADHDer, something that I observe is that she doesn't have mental stamina. So she has trouble getting started, but she cannot follow through. And sometimes with testosterone, it may even be where, you're spacing out like way more because your brain is just like fueling down. It's just like I'm powering down. And I have to share, these ADHD hormone profiles that I developed from the research and from my clinical practice. When I sent my book to publishers, to see like, anyone want to buy my book and like work with me on this project? There were several editors who took the quiz. And when I met with them, they were like, I figured this out. And I went to my doctor and I got a prescription. And 2 of those people were like, I was on estrogen and I was on progesterone, but I took your quiz and I realized testosterone was my issue. And now I'm back. I'm like the same person I was before. So the other thing I think is important to understand is that while everybody chases progesterone and estrogen's going to oppose testosterone, and all of these hormones have to be optimized together. Sometimes we give progesterone, and then I just had this patient consult a couple of weeks ago, and she's an endometriosis patient, but she's 48, and she says, I'm coming to you because my doctor put me on progestin and progesterone. This is very common in managing endometriosis. And she's like, and then I started having hot flashes. My skin is like really, really dry. My ears are itching so bad. My tongue is burning. So this is telling me right away, mucous membranes being affected, fluid production, oil production. Like we're talking about estrogen here. And her doctor said, well, I think we just need to switch and we need to put you on topical progesterone. And I was like, well, topical progesterone is going to do nothing for your endometrium. It's not really going to do anything for your endometriosis either. You're actually having symptoms of low estrogen. And she's like, but how? Like, I'm not, like, I don't understand it. I'm like, because we're given so much progesterone and progestin that it blocked out estrogen. And now estrogen's not able to do its job. And that same thing can happen when we start moving estrogen around like to testosterone. And so, I want women to understand testosterone is absolutely crucial in terms of your brain health and your brain function. And as women with ADHD, we can see worsening symptoms on either end. So you got too much testosterone. This is why I'm like just give someone 5 grams of the male testosterone, version, because like heaven forbid they actually make one for us, right? Like that can be way too much. Now, they're super impulsive. Like they're feeling like, they're
And you mean
starting
5
to
milligrams, right? Not 5 grams.
Oh, so the dose would be 5 milligrams, but
5
when you're
milligrams.
dosing the sachet, it's
Oh,
like,
okay, it's
measuring
5
out
grams.
the pea size amount. Yeah.
Yes, yes,
testosterone
yes.
is unnecessarily confusing because
Yes.
they have it for men and then they expect women to just use it. This is why sometimes like we'll compound testosterone with estrogen in a cream too. So it's just like easier. You do it all at once and we can really get that dose dialed in. And other times we're like using DHEA or maybe going that route. DHEA, so for people listening, that's a hormone that comes from the adrenal glands, is a precursor to estrogen and testosterone. And it's actually really important for ADHD as well. When we see DHEA go low, ADHD symptoms get worse. And presumably what you could extrapolate from that is that there's HPA axis dysregulation, because that's when the hypothalamic pituitary adrenal axis is dysregulated and you've been under chronic stress for far too long. Initially, acute stress, DHEA rises, chronic stress, DHEA becomes depleted. And now we start seeing worsening ADHD symptoms. And so I don't think that even though the research is like, oh, it's just low DHEA, I think it's low DHEA meets chronic cortisol elevation and that we're getting that like 2-for-1 hit on our brain.
Yes. Oh my gosh, my brain is exploding with all of this juicy, incredible information. So you have a plethora of resources for women to start. They can buy your book, ADHD and Women. They can take your hormone quiz and find out exactly how to self-navigate, where they should start and how to advocate with a provider, correct? And then
Absolutely.
they can also understand what diet/nutrients they can really custom tailor to themselves. So these are like already profoundly incredible tools. No matter what medications you're on, no matter what hormones you're on, you can still benefit and tweak and optimize. So where else can people find you as a whole on the internet?
Yeah, so you can
And
find me
learn more?
on the Dr. Brighten show. I'm also all over social media at Dr. Jolene Brighten, and I'm going to be releasing an app as well for ADHD women called Brambler, with no E at the end, which is the word for blackberries, which can be a little thorny, but also very sweet and juicy and wonderful and full of polyphenols. But and Brambler will have all of the quizzes from ADHD and Women. I came up with this because I was like, ADHD women, they're not going to have such an easy time just doing quizzes in a book and coming back to those things. And so I created this app so that they can take the quiz and get get their profile and get a protocol that they can start working through and be supported.
That is brilliant because, yes, your book is 400 plus pages. So, yes, it was
550.
550. Yes. And I was going to tease you and be like, how did you write a book for ADHD women? Well, that is so long. But there is so much. I mean, there are so many incredible resources in there. The recipes are gorgeous. Like, it is packed. And I do love the fact that you can open up a chapter. You don't have to read it cover to cover. You can dive in and still pull out incredibly useful things. And really, you're like the only doctor I know doing this level of work for women. I think it's so impactful. I think sharing your own lived experiences is so helpful to just normalize the conversation around neurodivergence. So I'm so grateful for the work you are doing. I know you're changing lives, and thank you for coming on today.
Yes, thanks so much for having me.
If you loved this episode, follow or subscribe to the Midlife Realignment wherever you listen to podcasts and on YouTube, and leave a review to help other women find this show.